by the time the things get set up, we have Dr. Vivek Verma from Delhi, Max, heading the unit. We have Dr. Pitanjali Singh, my sister as well, who's head of department, All India Institute of Medical Sciences, and Dr. Manisha Singh, ma'am, head of department, medical director of Mahavir Cancer Sansthan, Patna. So I welcome you all to the Anup Master's course. I know this is out of the way, but point is that oncology, oncosurgery, we see a lot of bone tumors. We just send it to somebody. So we did discuss about biopsies, and we have Daniel Potter, sir, who is basically a tumor surgeon, and more so in pediatric tumor surgeon. And he was heading the Edinburgh sarcoma unit when we were there. Potter patent team, sir, and I'm trained under him. All yours, sir.
Thank you very much, Ashish. Thank you very much, Mr. Chairman. Mr. Chairman, thank you. I thought that this course might have some Exeter interest because I heard originally there was an idea about that. So I put together a short presentation about use of Exeters in some pelvic tumors. Well, I don't mind doing that because, as you know, cemented hip arthroplasty is still a very valid option when we need modularity and ability to change the position of socket and stem. Of course, with the Exeter, it's the stem. So here's a case, a 15-year-old girl with, you can see, a tumor involving the gluteus region on the right side. And this is a tumor of the, involving the acetabulum and ilium. Traditionally, hindquarter amputation was the treatment, but more recently, internal hemipelvectomy has become an option. So this is the MRI and the coronal plane, and we can see it another cut. It's involving bone of the acetabulum. So this is really a partial hemipelvectomy that's going to need to be done, as well as soft tissue dissection, removing the femoral head and neck. So where's the resection going to be for that? We can use a number of different types of hemipelvic endoprostheses. This is one that's on the market, a stemmed cone acetabular prosthesis. We did a lot of that with a resection involving the acetabulum, just leaving here a small amount of the posterior ilium up to the sacroiliac joint. This is the reconstructive X-ray, and you can see we use an Exeter stem. And you know, when we've done all this hard work, we put in an endoprosthesis. It's a lot of time on the table. We want something relatively quick and that's going to be reliable for the femoral fixation. And an Exeter will do that to give us the ability to put the stem where we want to put it. And here, of course, we had to reconstruct the vastogluteal sleeve because the trochanter had gone. A dual articular socket. And I think later, we may hear more about dual articular sockets, which we look forward to. We do two incision approaches for pelvic resections. That is an extended Cocker-Langenbach and also an ilioinguinal approach, extended ilioinguinal. Other cases from our series, but again, you can see we're using gloss tapered stems, Exeter stems. 27 patients had these in our series. Follow-up up to 18 months, so relatively medium-term follow-up. Obviously, some complications, dislocations requiring surgery, but not in a captive device, which we use more laterally. A few infections, as we might expect with such massive surgery, and 2 local recurrences in metastatic disease. Moderate Toronto extremity severity scores, and the key point is that the cost significantly reduced compared with more standard pelvic resection types. Compared with other series, ours was simply a case series. We didn't do any randomization or comparator studies apart from looking at other studies in the literature, and overall costs are reduced. So in summary, a stemmed cone prosthesis is relatively safe and effective in comparison with others, simple and rational to use, and minimizing loss of bone stock. It's less expensive than other custom-made implants, and the femoral side can be a standard femoral implant, such as an Exeter. Here's another case. We can see something happening in the ischium of this 57-year-old lady, and the MRI shows high signal on T2. This is a cartilage lesion, a medium-grade chondrosarcoma affecting the acetabulum. So again, this is the chondrosarcoma, we aim to resect this. Bone scan simply showing the disease in its primary location, not elsewhere, and a negative CT of the chest. So we went on and did, again, a stemmed endoprothesis. So captive socket, extra stem. It's a reliable and effective reconstruction. And with this relatively small amount of metal, a post-op MRI is also possible, so we can look for recurrence without a great deal of interference, which is nice. So other cases in which we use extra stems for pelvic reconstruction, metastasis around a breast cancer, and in prostate cancer, significant osteosclerosis, we can overcome this. Some of these cases would definitely, Ashish, benefit from navigation, which we didn't use as frequently in times past as we would now, and which you'd be able to do. And just finally here, multiple exostosis, which I'm going to come on to, one of the conditions that I have a big interest in. This is a first paper on the hip in HME from the BJJ more than 20 years ago, 25 years ago. And one of the features of HME around the hip in a large number of these patients is that there's no dysplasia, but there is coxa-valga. Coxa-valga is a big problem. It's a feature. It becomes a problem if it develops into osteoarthritis. This is all our series of coxa-valga. Almost all patients demonstrated coxa-valga, but not all patients demonstrated dysplasia. And the number of exostoses in the proximal femur related to the chance of coxa-valga occurring. So here's an adult patient. We've got maybe just you can see that there's a misshapen femoral head. There's the exostosis development along sessile exostosis on the medial calcar has extended up to involve the femoral head, and it's not a spherical femoral head. So arthritis has developed, and an exeter is a very real possibility here. It's a fairly straightforward procedure. The main problem is identifying where are the neck landmarks because of the exostosis development. It's quite difficult to find the lesser trochanter. But again, because this is a cemented option, we've got modularity, which we can make use of to get the right tension in the soft tissues. Okay, so that's my presentation about use of exeter around tumors in the pelvis. Use what you're used to using. I mean, if you're a Stryker user, use Stryker. If you're DePuy, use your C-stem. Use what you're used to using. A conventional exeter stem with appropriate articulation is suitable for femoral fixation in complex primary tumors. It's reliable and it's flexible. And therefore, consider cost to the patient. Use what the patient can bear, considering what outcomes you're aiming to achieve, and exeters can be reliable. Okay, thank you. I'd like to just, is it reasonable for me to move on to the next presentation?
Yes,
Yes, sir. Yes,
Dr. Daniel, probably we can take a few questions from this session. So I have one question. In your last slide, you said consider cost to
consider the cost to the health system. Training there, that we taught young doctors that they had to consider what was going to happen to healthcare costs if they just prescribed without thought to the burden on the insurance budget. So whether it's the patient in front of you who's paying, or whether it's somebody up here who's paying, I think it's the morality of a doctor has to consider that. What do you think?
So if I could just ask, thank you for your very elaborate discussion on this new thing. Since you are dealing with pediatric tumors, so I would like to ask your experience on how do you manage their growing bones?
Long bones.
Growing bones, yeah.
Long bones.
No, no, the growing bones. The bones are
Growing
still
bones.
expanding.
We had a presentation yesterday about some options there. Depends on the age of the child. So a child that's approaching the end of skeletal growth in their teenage years, we can usually use an adult prosthesis. We're able to add a little length. And even if it's involving sacrifice of a growth plate, they're not going to end up very short. So in an adolescent, still not fully grown, then that's the usual way forward. In a child, it's a bigger problem. And biological reconstructions that sacrifice joints have problems because the problem of the articulation and the problem of degeneration, osteoarthritis developing later is a very real one, sacrifice of a growth plate. So endoprostheses have the advantage of perhaps incorporating a growing component. And traditionally that was first of all taking out a segment, putting in a longer segment. That led to its own problems of multiple surgery, increased infection risk. The next generation was a screw system by which a screwdriver was introduced to a gearing system that would lengthen every 3 or 4 months, could be lengthened by a few millimeters. And then more recently, a magnetic-driven internal system, the power from the magnet would drive gears to increase the length of the bone without any surgery necessary. All of these have got their own complications, but it does limit the increased infection rate and the requirement for future surgery. It's a problem, and there is no easy solution if you have to sacrifice growth plates.
I have one more question before we move on to the next talk. So you said we take dual incision with Cocker-Langenbach and ilioinguinal. So do you face the problem of flap necrosis, or do you use primarily a plastic surgery flap during surgery?
Yes, so with these two approaches, we can separate. There's a skin and muscle bridge of more than 10 centimeters. And what we have found is that this is quite sufficient to not have necrosis. And it's reliable in that regard.
Thank you. So we can move on to your next talk.
Thank you, sir. I would like to continue with the next topic, sir. Management of osteochondromas and multiple osteochondromas.
Thank you. So this is a very large topic which can't be covered in a short time. And I've just decided, for the benefit of what I thought was going to be the main themes of this conference, to concentrate on the lower limb and mainly limb alignment problems, but not entirely. So hereditary multiple exostoses, these are benign neoplasms, but we know that they're associated with deformity. The tumor, and in fact in multiple exostosis, the blood of patients with the condition demonstrate a mutation in the gene we call EXT, either EXT1 or EXT2, and these are some of my patients demonstrated. You can find the mutation, and it's responsible for cell surface glycosaminoglycans. And the two mutations generally are either EXT1 or EXT2, two different proteins, but they combine together to create this cell surface protein. And if in the patients that I had in Oxford and Edinburgh, we looked at all the different mutations. We could find most of them on EXT1 and on EXT2. And in the mouse, we can knock out the EXT, and with these little mice develop exostoses on the ribs like that. So the first hit is genetic, the second hit is sporadic, and in the inherited form, and in the sporadic form, both hits. In the non-inherited form, the solitary form, both hits are sporadic. But then subsequent accumulated abnormalities might lead to the development of a large exostosis, one in the pelvis that didn't degenerate at the end of skeletal growth, with a potential for malignant change in a few percentage of patients with multiple exostosis. Well, if these are tumors and they're deformities, is it possible that the osteochondromas can cause most of all of their effects locally? The deformity, is it actually related to the exostosis locally? And this is a live question. And there's a fair amount of evidence that these two are linked. But the bigger question is that if you remove an exostosis, can that prevent future deformity? Can it prevent it? You know, here's an exostosis at the tibia. It's indenting the fibula. You know, is there going to be a chance of some valgus deformity occurring at the ankle in the future? We don't have a crystal ball, but removing the exostosis will certainly make the fibula remodel. Whether it makes a difference to the deformity potential at the ankle is another question. We did look at all the evidence relating to this in a larger review, evidence-based pediatric orthopedics, and the question in this large review, does excision of exostoses arrest or reverse the development of deformity? All the level of evidence was level 4, case series alone, and the level of evidence in favor of this was poor. So we can't say for sure whether it is going to help, but it might. Problems of exostoses in the lower limbs are, of course, they're just there, they're cosmetic, they may be causing symptoms due to pain or impingement, they may block range of movement. There may be deformity with or without instability or dislocation of, say, the hip joint or the ankle joint. There may be pressure effects on nerves, vessels, pleura, that's not the upper limb, but can occur, and malignant change rarely, usually in the 3rd to 4th decade of life. Here's a student aged 18 with multiple exostoses, a rapidly increasing right medial thigh mass and pain. So this is the x-ray. This child, or teen, how old was he? 18, sorry, this 18-year-old lying on the couch with a poor pulse and a rather pale foot and a large swelling. The on-call team thought this was maybe a sarcoma, but with the pale foot, we got a Doppler scan, and this showed a large cystic swelling adjacent to the femoral artery with a pulsatile profile. So within a few hours, underneath sartorius, we can see a large mass, which is a pseudoaneurysm. This is excised, and here is a sucker on a hole in the superficial femoral artery. What causes it? This is what has caused it, a degenerate exostosis, sharp as a knife, that has just cut the superficial femoral artery lining. I thought this was a one-off, but just a year or two later, this boy turned up. Looks like a knife, and this is a chronic situation, not acute, but has developed over a few weeks and months. Another pseudoaneurysm, so we sent him to the vascular surgeons for evacuation, repair, and we removed the exostosis. But what about the other side? Is that going to go the same way in a few months' time? Could do. Now we're thinking about deformity. So this is a boy with a clear valgus deformity at the lower limb. Long leg x-rays suggest the deformity is mainly based in the tibia, and we can see on this lateral x-ray an enormous exostosis. But where is it? We can see that there's an effect on the tibia, but where's it coming from? And it's actually sometimes difficult to see on the x-ray, and we need cross-sectional imaging. Before that, we can see the alignment of the lower limb. The weight-bearing axis is well to the lateral side of the joint. We can measure angles of deformity at the tibia in both planes. And cross-sectional imaging shows that this is a lesion that's arising from the fibula. A massive exostosis indenting the tibia, and this cross-sectional image shows clearly how that would be. No real concern about the cartilage cap. So we remove this and correct the alignment in two planes. And in doing that, we can see we've done that. We've had to remove a section of the fibula, but it's an effective operation for unilateral, solitary exostosis problem. It's not a solitary exostosis, but it's a solitary problem caused by a massive exostosis. What about the other side? Now we've fixed one side, the other is becoming apparent. There's another large exostosis on the fibula on the other side. And this boy underwent underwent a further plate osteotomy and realignment. So here's another boy, and he's in his teenage years, and He's really very bow-legged. He's got significant genu varum. He's got no pain and no symptoms at all, but he was worried because his father was like this. This is his dad. And his dad had already undergone a knee replacement at the age of 50, and this right knee was working very well. I did that one, and I was hoping to do the other one, because it would look like this, but before I could get to it, our managers had taken him off the waiting list and sent him to the Jubilee Hospital, where Kalpesh works, and they did a knee replacement that we had to revise, unfortunately, and that ended up as a problem for him. So this man ended up with 2 knee replacements, and his son didn't want to end up with knee replacements. So we had to think what to do about that. It's a complex problem. Actually, this one is involving deformity of both tibia and femur on this side, perhaps mainly the femur on the right side. We ended up, because he didn't want multiple surgery. His father had gone through multiple surgery. So we just did a single osteotomy and at the level of the femur. And blade plates are highly effective. You may think, well, what are they? They're very old-fashioned these days. But it may be that some of you come from hospitals where blade plates are still an option, which can be used cheaply for patients without the worry of excessive costs. They're effective, and it's a skill that I hope you haven't lost, how to use a blade plate effectively. How much time have I got, or should we finish?
Sir, you can please continue, sir.
5 minutes? 5 minutes, okay. So here's a younger child, a girl, and this is a younger child, and we can see on this alignment view that the left knee is going into valgus. And in a younger child, it's more suitable to consider guided growth mechanisms to correct this. So we get further x-rays to confirm where are the exostoses. Any of them need to be removed. And where are we going to put our guided growth screws? So the advantage of this is, of course, no big surgery, no plaster. They can walk, but you've got to watch them. You know, you can't let them go. You've got to have them coming back to see you. So if they live 500 kilometers away and you can't see them again, it's not ideal. So guided growth here, just a tibial 8 plate, and over the course of 9 months, this corrects itself. So I show this to show that it's not only the knee, but the ankle is a problem. We get this impression from this long leg view that something not right with the ankle. So let's x-ray the ankle. There's a CT here. Here's the, go back to the CT. So here's the ankle x-ray, and wow, this is something obviously going wrong here. We can see that the talus is shifting away from the medial malleolus. When you start to see this, you can't leave it. You've got to do something, and it's probably already a little late. The shape of the epiphysis is a delta epiphysis. It's not square anymore, and again, that we should have identified that a little sooner. We find that this is now at a point too late for an 8 plate. So an osteotomy individualized and angled so that we can correct the deformity. In a child where we've got open physes, K-wires, and then a plaster are very reliable fixation methods or stabilization methods until it heals. And after healing, we've got an ankle that we hope will be durable through at least most of adult life. So we could apply, in a younger child, we could apply an 8 plate to the ankle itself, where deformity has not yet progressed to that point. So we mentioned removal of tibial exostoses could correct deformity. What about this case? Shortening and contralateral valgus. So here we've got a leg which is shorter on one side than the other, and there's valgus deformity, and we have to consider how to deal with this. We could use, again, guided growth 8 plates. These days we might use two on each side in order to reduce the risk of breakage of the 8 plates, and at the same time allow the angular deformity to be corrected. Well, I've run through a few cases of lower limb malalignment problems. I'd like to just finish with mentioning my method of following these children up. And I review them every year up to the age of 18. More often, if there's a problem that needs more frequent observations. I examine the whole body and document their palpable exostoses. I measure leg length. I document the hip range of movement. I document knee alignment in the coronal and sagittal planes and ankle alignment in the coronal plane. For the upper limb, radius and ulnar relative length, and whether there's radial head subluxation or not. Range of forearm rotation, digital alignment, and any other features. I will X-ray new problem areas and consider cross-sectional imaging if surgery is planned. And after the age of 18, I get a final X-ray of the pelvis to decide on follow-up whether they have any risk of exostosis in the pelvis becoming degenerate, because it's usually in the axial skeleton that these chondrosarcomas will develop. So this is my method of looking after patients with children with multiple exostosis, and I recommend it to any of you who are also seeing these children. Thank you.
Thank you, sir, for sharing valuable work with us. Now I ask Dr. Vivek Verma, sir, to start his next session.
Yeah, so just I think 2 points I want to make about this. Like primarily for exostosis that we see, the indication is primarily for the cosmetic as well as for the pressure symptoms to remove that. But I think you presented one of the other important points, that to correct the mechanical alignments also, so that the deformities are well corrected. And second point, what about that case where there was a pseudoaneurysm on one side? Because we commonly see such cases with a medial exostosis along the distal femur.
Yes.
And that patient had the opposite side also. So did you operate prophylactically on the opposite side?
Well, I get a CT scan to have a look, see how sharp is this piece of bone and how close to the femoral artery. I think it's then up to the patient. You know, we can mention there is a risk, and if you develop pain and swelling, we have to do it because maybe there's been a pseudoaneurysm. But it's difficult to say you've got to do it.
Thank you.
Thank you, sir.
Thank you.
So I'll request Dr. Portal to join us for this session on the stage as well as for the upcoming panel discussion.